All right, so now we're going to go into Module 5, Treatment for Anxiety. This module is going to be a lot faster than the previous ones because most of our treatments for anxiety we've already discussed in major depressive disorder, with a few differences. In general, they require lower doses than depression treatment, and then there's a few extra medications we can use that are just as effective but have different mechanisms of action for anxiety, and then we'll talk about a few that maybe have specific anxiety disorders that we want to use those drugs to target with. The beginning of this presentation is the epidemiology and the symptoms of anxiety. So we're going to skip through these. One thing you do want to rule out for anxiety disorders is medication causes. This can be common if you use CNS stimulants, Adderall or Ritalin for ADHD. If you have comorbid anxiety or a misdiagnosis of ADHD, this is a stimulant, so it's going to activate the patient and it's going to cause any anxiety could cause it to worsen. CNS depressants are not as common, but that could be for the children and the elderly. It's often dose dependent with rapid onset, and you want to always ask a patient if they've developed this, have they started anything new. The other medications that can cause it, prednisone, that's a big one. Steroids do cause psychiatric disturbances. And side effects, I've seen people who've become catatonic on prednisone. People have developed horrible anxiety. One patient who was very, very much appeared bipolar, but she was 33 years old and had never had psychiatric symptoms before. They had to. It took her months to get back to normal. But once she was finally off the prednisone and medicated for a few months and had some ECT, she's returned to normal with no need for medication. It's just a long recovery. So steroids can cause it. Decongestants, pseudoephedrine and phenylephrine increase the heart rate, can worsen it, and stimulants. Then there's a few other medications here that can worsen anxiety symptoms. But the main three are those ones bolded in red. So obviously neurotransmitters there's a theory behind serotonin, norepinephrine, and GABA, which explains the medications we're using for these disorders. And all of our disorders have similar features. The symptoms of anxiety, of the panic attack, the chest tightness, the tachycardia, the sweating, all of that is fairly similar between each one. It just depends on when it happens, how it happens, and where it happens, and what the cause is between the disorders. It may affect employment, health, social life, and mobility, depending on which disorder it is. Social anxiety versus panic disorder versus generalized anxiety. It's going to affect different areas of the patient's life. There are standardized rating scales. We're not going to get into those. Mostly they're used in trials and to prove efficacy. You can read through those if you want to. For generalized anxiety disorder, we're going to skip straight to treatment options. So this one is pretty straightforward, where you've got SSRIs and SNRIs along with non-pharmacologic treatment options, psychoeducation or CBT. If you can convince your patients to use one of those, they're going to have better outcomes long term. For the most part, with treatment of anxiety disorders, patients want medication because that is a quick fix. Is a terrible word for it, because I don't mean for it to sound like it's a band-aid. It's a necessary treatment option, but it only works as long as the medication is continued. Whereas psychoeducation or CBT teaches them coping skills and to process the root of the anxiety, and it provides a more long-term, lifelong treatment versus medicine. But medicine's cheaper. insurance doesn't cover the psychoeducation enough, and they have to take time off of work, go to appointments, continue to work on it. Whereas the medication they can just take and let it do its job. As far as treatment options, again, SSRIs, SNRIs, buspirone, which we'll talk about in a few minutes, and benzodiazepines. So the way this lecture is set up is it talks about the different treatment options for each disorder, and then we're going to go into the individual medications themselves where they fit, because you're going to see some combination of these for each disorder. Social anxiety disorder is CBT, very important. Combination works best, along with SSRIs or SNRIs. Benzos and buspirone or buspar are not indicated for social anxiety disorder. Panic disorder is CBT, very important, or non-pharmacologic, very important. And you're going to use SSRIs, SNRIs, and then benzodiazepines. And for all of these, the benzodiazepine should be a PRN medication. We're not looking for maintenance medication. This is a PRN for a panic attack, or for in general anxiety, for increased anxiety, short term. We're not looking at having patients on these long term with benzos. Separation anxiety, mostly non-pharmacologic. There are no FDA approved treatment options, but SSRIs and TCAs do have the best evidence for medication. Obsessive compulsive disorder, non-pharmacologic is the most effective, and then first line treatment is SSRIs. This is the only time you're going to see fluvoxamine, which we'll talk about in a minute, is an SSRI with the only FDA indication of obsessive compulsive disorder. It's pretty effective for that. If available and the patient can tolerate it, I'd go with that first, and then other SSRIs after that. Following SSRIs, if you don't have full remission, or they can't tolerate it, you can go with clomipramine, venlafaxine, and then for treatment-resistant options, you would augment with antipsychotics. Obviously, all these medications are going to have the same side effects and contraindications as when we talked about antipsychotics for schizophrenia, or SSRIs for major depression. Just in general, you don't require as high of a dose to treat anxiety as you would those other disorders. PTSD is non-pharmacologic, that using exposure therapy, CBT after the event, and then eye movement desensitization and reprocessing. If PTSD is something you're interested in treating, that's an interesting topic to look up. PTSD, the big thing is you want to use SSRIs or SNRIs, and you absolutely want to avoid benzos in PTSD. There's a want to use it in the beginning to lessen the panic attack, or the event that the patient is having that is induced going back to that same location, or the event. But benzos actually make symptoms worse in the long run. So we want to avoid benzos at all costs in PTSD. So treatment options, as we're going to talk about just the medications themselves. So the goals are short-term, decreased duration and severity of the symptoms, and improved daily functioning. And long-term, we want to get to remission with no impairment of daily functioning at all. We have non-pharmacologic and pharmacologic treatment options, with the best treatment always coming from combination therapy. Like I said earlier, non-pharmacologic is harder, it's more expensive, and it is harder to schedule, and patients will prefer it less than pharmacologic, but it is more effective than pharmacologic in general. But combination is always best. Pharmacologic treatments in general are antidepressants, so SSRIs. That is based on efficacy and most antidepressants are equally effective, but SSRIs are still the most tolerable and the safest in overdose or and less drug interactions. Second line would be SNRIs for the same reasons as SSRIs. The only problem is with SNRIs, you do have that norepinephrine. There's a potential for increased blood pressure, might kind of mimic an anxiety symptom. So you may have a patient who just doesn't tolerate an SNRI very well. For benzos, you will want to use them only to treat symptoms, not underlying anxiety. For your antidepressants, you do have an increased risk of anxiety in the first couple of weeks of therapy, so they may need a benzo for a couple weeks until the SSRI really starts to work, and then you may want to cut down on their PRN medication. So let's say you tell a patient, okay, I'm gonna write you a prescription for Ativan. Let's say they don't need much, 0.5 milligram, Q6 hours PRN anxiety attack, and we're starting them on Zoloft. Then after 2 weeks, we may want to go to have it Q8 hours, Q12 hours, and then cut back the numbers that are available, or how often they should take it, as this, so that in a month they're not using the benzos, on a more scheduled routine basis. It's just a as needed, every once in a while. I had a panic attack today. I haven't had one in several weeks. That you might want them to have, just a couple on hand just in case, but it wouldn't be a, twice a day kind of thing. Third line, and these are just based on the types of panic disorders they treat. Hydroxyzine, whether it is Vistaril or Atarax, they are used the same. They are dosed the same, 25 or 50 milligrams. You can give them, 4 to 6 times a day as needed for anxiety. But the only difference is Vistaril is hydroxyzine pamoate and is available in a capsule. Atarax is hydroxyzine hydrochloride and is available in a tablet. Efficacy-wise, there's not a big difference. Cost-wise now, there's not a big difference. But they're not interchangeable when you go to the pharmacy, because they're different chemical compounds, but they work the same. So they're just, you can, you write for Vistaril or Atarax. You can't interchange them both just on a prescription. So make sure you're clear when you write a prescription which one you want. Don't write just hydroxyzine, because they're not going to know which one they can do, and they can't pick for you, because we're not allowed to prescribe. So as far as generic substitutions go, we can only substitute the literal generic. We can't pick which hydroxyzine. Buspirone, we'll talk about in a minute, is approved for generalized anxiety disorder, and that's all. And then you have TCAs, MAOIs, gabapentin, valproate, and even some antipsychotics, which are just for treatment-resistant patients. So SNRIs, SNRIs, all of the agents are effective. They, common side effects: increased anxiety, GI upset, and agitation in the first week or two. You're going to see efficacy in 3 to 5 weeks, maximum effect in 8 to 12. Again, just like antidepressants, it doesn't matter what we're treating. They're going to work the same and have the same kind of time frame, but you usually start at a lower dose and then can titrate up based on which dose the patient needs. Here are the FDA indications for SSRIs. Now, looking at this, you can see Paxil's approved for all of them. That's great. I don't like Paxil. I don't think it's tolerable, or it has too many drug interactions, or I'm not. We talked about that in the antidepressants. I'm not a fan of Paxil. But looking at this, does this chart mean that Zoloft doesn't work for general anxiety disorder? No, it does work. We know it does, but FDA indications have to have specific trials placebo double-blinded trials, and then they have to submit the paperwork, the documentation, pay the money to get approval, and all of these are generic now. Nobody is going to pay to get FDA approval for these things. So this is what's FDA approved, but in general, they all work for all of them except fluvoxamine. I would not recommend it for depression. I would keep, or generalized anxiety, I would keep it just for OCD and possibly social anxiety disorder. Sorry. Come on, there we go. Again, SNRIs, you can see what they're indicated for. I think we have the most effect in anxiety with venlafaxine and duloxetine. I don't see Pristiq and Fatzima used for the other ones, and that probably is also due to the cost. They're name brand only, so most people will go with other options for those medications. You can see what the doses are for these medications in general for anxiety. Couple counseling points, like we talked about earlier, it's the increased anxiety symptoms in the first 2 weeks. Let them know, or they might be likely to stop it, and they may need a benzo to cover that time frame. And the time to full benefit can be up to 6 months in these medications, longer than if you were treating depression. So that's something to keep in mind to tell the patient that it's going to take time. Yeah, it's not a take a tablet, feel better tomorrow. Like a blood pressure medication, or treating diabetes. That the number's good, so let's we're taking one dose. Other antidepressants can be used. You can see tricyclics, clomipramine. You'll see that used some, and imipramine, but there are downsides to it. MAOIs you're not going to see used for anxiety anymore. I mean, they have effect, but we just have too many other options, and there's too many downfalls to MAOIs to use it for anxiety. Benzos. This is the first time we really talked about benzos in this class, and given the fact that everybody's on benzos, you would think it would come earlier. There's definitely an overprescribing of benzos, and once a patient's on it for several months, it realistically takes a couple months to titrate off of it. I think what ends up happening is a patient will be taking it a long time. We'll try to cut them down, and we titrate off too quickly. And so you get a rebound, symptoms, and then it's just assumed that we have to be on it for long-term treatment, and that they never try to come off of it again. But we want to give them the respiratory depression risk and the tolerance built into it, the dependence. Then we definitely want to use benzos as little as possible. It is very common to use for anxiety, trying to overlap only in the first 2 months until the antidepressant is effective. It only treats the somatic autonomic symptoms. It doesn't treat the underlying anxiety disorder, which is what we're trying to do with the medication and the therapy. They're all equally efficacious. As far as benzos go, the differences in most benzos, and we'll show it in a chart later, is how quickly they work and how long they work. So Xanax, everybody's familiar with Xanax, starts working in minutes, 15 to 30 minutes, and you can give it, you can get over 2 to 4 hours if you really had to. Whereas Valium starts working in a couple hours, but you can theoretically do it once a day. It's just a longer acting benzo. So you need to keep that in mind when you're picking which benzo to use. So benzos work through by binding to the GABA receptor, and GABA is our inhibitory neurotransmitter. It's the kind of the opposite of glutamate, which is excitatory. So it results in basically negating those excitatory neurotransmitters. You want to individualize the dosing, start very low and titrate up. So that you alleviate symptoms and avoid side effects. You are going to want to most likely divide the dose throughout the day. So we're not giving one in the morning and letting it go. They're going to probably need 2 or 3 doses during the day if they are needing it somewhat scheduled. for the first couple weeks of antidepressant use, and that helps with actually treating the symptoms of anxiety, but it also kind of creates a kind of a placebo effect for the patient. I'm taking something 3 or 4 times a day, so that keeps it fresh in their mind that they are taking something, they have something helping, and it does help patients who are the beginning of treating their anxiety disorder. So they're working through how do I function in my day to day life while trying to treat this disorder. So it does help. Maybe Ativan 2 to 3 times a day, Klonopin 2 to 3 times a day at a lower dose to kind of have that placebo effect, and in addition to the actual efficacy of the medication. Just that reminder of taking medication several times a day. So you can see here, benzos do have an equivalent dose. There are lots of charts that talk about this. There's several on Canvas that I've posted that we've made throughout the years on the dose ranges, equivalent doses. It adds in, the half-life, the peak onset. You can see the number of hours here, whether they're rapid, intermediate, or long-acting. So, the daily dose range, comparative dosing. So there are lots of charts that talk about this, and that's what you want to base which one you're going on, how quickly you need it to work, and how long you want it to work. So benzodiazepine side effects, obviously sedation is a big one. It's an inhibitory medication, CNS depression. So tolerance does develop fairly quickly. And so you're going to want to, in a couple days, they'll get used to it. So you start low and titrate up, because there's a real risk of, if they're driving a car or operating heavy machinery, of really having trouble with that, and it's a safety risk. You can also have confusion and disorientation, irritability and aggression, excitement and memory impairment. Those are a lot less common than benzos, but it's kind of like a too inhibited kind of thing, where they'll get confused and irritable because of that confusion and excitement. Kind of like an Alzheimer's patient becoming confused. Drug interactions, obviously avoid alcohol. Too much can be fatal. It works in the same pathway, which is why we use benzos for alcohol detox. Ideally, we would avoid other CNS depressants also, and like narcotics and antihistamines. And then our elderly and children are going to be more susceptible to those drug interactions. Disadvantages are development of withdrawal, tolerance, abuse, and dependence with use, which then takes a long time to taper off. If we taper off too quickly, we get rebound anxiety. And usually those symptoms are more intense than the original symptoms, which will then lead your patient to saying, I can't come off of this ever, which is never a good thing. The recurrence of the anxiety, is return of the original anxiety symptoms, not rebound anxiety. And about 50% of patients will experience some kind of rebound within 6 weeks of stopping, especially if they're not on another medication to help treat it. So patients who are given benzos long term will eventually become tolerant or dependent. It is not. It's not really habit forming. We're not talking about illicit drugs or opioids where they're like an addiction. It is just a tolerance or dependence on. They will become symptomatic if they don't have it. They will have kind of withdrawal symptoms if they don't have it. So your faster acting benzos are more likely to be abused, with Xanax being the top one. Xanax is definitely abused. The name brand Xanax is made in, it's like the 2 milligrams. You'll hear them called totem poles, and it was basically made as a bar that, like, 2 milligrams would have 4 squares on it side by side, and you could break off one square if you only needed part of a dose. So people who are trying to get it through legal means, you'll hear them called totem poles. And there's some that are got yellow jackets and all kinds of stuff. But benzos are definitely abused, usually abused by people who weren't prescribed them to begin with, or if they already have some kind of abuse disorder with another substance. There is something to keep in mind. There is a paradoxical effect in patients who have mental retardation or patients with dementia. So it actually is it's a stimulant, it can be a stimulant, not an inhibitory medication. So keep that in mind in those patients. We try to avoid benzos in those types of patients because it definitely has a paradoxical effect. Here are the symptoms of withdrawal. You can read through these. They're mostly because of the withdrawal of benzos is not nearly as it is not potentially fatal like alcohol withdrawal. It is uncomfortable. It's not fun, but that's the worst of it, is that it's uncomfortable. And most of that is because the tapers are just done too quickly. So if I keep saying they're done too quickly, how slow should you go? So the general strategy that I don't think is followed nearly enough is to decrease the dose by 25% each week until you get to half the original dose. And then you want to decrease by 1/8 of that dose every 4 to 7 days, just say a week. So if a patient has been on it for greater than 8 weeks, it's going to take, you want to do it over 2 or 3 weeks. But if it's been over a year, you want to taper them over 2 to 4 months. That's a long time to taper somebody. So most people you'll try to do it over, 2 weeks, and they've been on it long term, and it doesn't go well. So what happens if a patient does overdose on benzodiazepines? Well, we do have flumazenil. It's basically an antagonist of the benzodiazepines. It competitively inhibits the GABA receptor. It's given by IV dose, and the adverse reaction is seizures, which makes sense because we give benzos to treat seizures. So by cutting the benzo real quickly, you can induce a seizure in somebody who doesn't have a seizure disorder. But that is a worthy risk for patients who are overdosing on benzos. Buspirone is another medication we can use to treat general anxiety disorder. It is, I think it's a decent medication. It's far less sedating than benzos. It's actually really well tolerated by a lot of patients. It is only approved for general anxiety disorder, and it works by binding to serotonin and dopamine receptors. It does not affect GABA, so it doesn't have that CNS depression. There's no risk of having an interaction with alcohol and other illicit drugs. So this is a good option for patients who may have a substance abuse disorder. It works more like an antidepressant than a benzodiazepine, so it does take several weeks to reach full effect. It can be monotherapy or adjunct. Some patients may be comforted by the multiple times a day dosing, so it can be given 3 to 4 times a day, between 15 and 45 milligrams, and some patients like taking. It's the same thing with the benzos, having it multiple times a day. Sometimes it makes patients feel comforted that I get a dose of my medication at breakfast, lunch, and dinner, and I know it kind of has that placebo effect of getting it multiple times a day. So in general, patients either love buspirone or they hate it and say it doesn't work. Now, a lot of the time, I think patients who say it doesn't work, it's because that it's come after a benzo trial. So you've had a medication that you feel the effects of a benzo. If one of us if somebody who doesn't have an anxiety disorder, let's say you give me a benzo, I'm going to know in a couple hours that I had a benzo. I'm going to feel something. So, Buspar afterwards, following that benzo, you're not feeling anything. So you're going to say, well, this doesn't work. But a benefit is that it doesn't have those interactions. There's no dependence, there's no withdrawal from it. But the downside is if it's coming after a trial of benzos, it may be viewed as less effective by the patient. It is second line for due to inconsistency in data because it's only approved for generalized anxiety disorder, and there's a delayed onset like antidepressants. So you can see the dosing here, starting with 15 milligrams daily, titrating up to a maximum daily dose of 60 milligrams daily, and you can do it, 2, 3, 4 times a day if you need to, whichever the patient prefers. And it has similar side effects to SSRIs. So you can here's an example of an initiation of Buspar for a patient. Atarax and Vistaril, which again are both hydroxyzine, they're different salt forms. I'm not going to bore you with the chemistry of it, but the hydroxyzine, the effective part is the same, but it's how it's made into where it can be put into a tablet or a capsule is different. So Atarax is hydroxyzine hydrochloride. It is a tablet. Vistaril is hydroxyzine pamoate, and it is a capsule. Now, I can tell you they're both equally effective. Recently, in the past 2 years, we had to switch my hospital from Vistaril to Atarax because Vistaril was on back order. It just wasn't available nationwide. So we switched. We didn't have any decrease in efficacy from the patients. We tend to go with Vistaril to begin with. I think it was a little cheaper at that point. I'm sure when Vistaril comes back, we will also we might switch back to it, but they both can be used. It is an H1 or a histamine or antihistamine. You can give it in up to 100 milligrams 4 times a day, scheduled or as needed. I think it's better as an as needed medication. Safety issues are cautions in BPH, respiratory disease, glaucoma, and the elderly because it's an antihistamine, so it is on the Beers list for possibly being intolerable to the elderly. You can see here there are side effects. Usually those side effects go away with the first couple doses. Monitoring, blood pressure. If the patient is feeling lightheaded, you wouldn't routinely monitor blood pressure. And then interactions are just additive effects with antihistamine, MAOIs, and CNS depressants. Alternative agents, you can use gabapentin or beta blockers for social anxiety disorder. Beta blockers are great for like performance situations. So if you're in a presentation or you get very nervous talking in front of people, you can take propranolol or atenolol an hour before the performance. Obviously, the first time you don't want to do it the first time right before your presentation. You want the patient to try it a few times so they make sure they're not going to fall out because of hypotension, during the presentation. But start at 10 milligrams and let them try that a few times to see if it helps them get through their presentation. Alternative agents for PTSD, you can see them listed here that you can go through. We're not going to talk about them very much because we have talked about most of them. The one thing we are going to talk about is that prazosin. It's an alpha-1 antagonist, so it's an antihypertensive medication, but it's got pretty decent evidence for decreasing nightmares and improving sleep for patients in PTSD. It does not affect like daytime symptoms, but it is, depending on what source you read, it's good for nightmares. So you can use that for patients who have PTSD. Obviously, because it is an antihypertensive, warn them that they could have low blood pressure. So when they're getting out of bed in the middle of the night, make sure they sit at the edge of the bed for a few minutes before standing up quickly because they may have orthostatic hypotension. In general, treatment strategies, initial therapy is an SSRI and CBT. Start low and go slow and titrate up to your higher doses. If no response with SSRIs, change to a TCA or another antidepressant. And you can add other medications as needed for symptom control. In general, for treatment resistance, there's no real guidelines available. So you're going to want to look and see if you've had an adequate trial offered, 8 to 12 weeks, the maximum or appropriate dose. Try different SSRI or SNRI, and then consider augmentation with buspirone and antipsychotics. So that's it for anxiety. If you have any questions, let me know.